Hello, everyone. This is Fazia. Welcome to our webinar on PAPANA Mental Health Awareness Program. We will be covering many topics that we care about and continue to include content related to mental health issues that you need to know, with a broader focus, including underserved South Asian minorities. We look forward to you bringing many more sessions and keeping our commitment to elevating expert voices on these issues. We are excited about this program, and we appreciate the time you all spend with us. Today's topic is in recognition of Suicide Prevention Month worldwide. We have started a series on suicide prevention awareness, and today the topic of our webinar is youth suicide prevention. This is a very important topic, as the suicide death toll among youth is alarmingly high. To need to know who is at risk, and when the risk is greater, we need to understand this topic very closely. And I believe this session is going to provide you with a lot of valuable information on this topic. I will be moderating this session, and after the presentation, we will be taking your questions to be answered by our speakers. And please feel free to write your questions in the comment box so we can assure they are answered in this session. So first of all, I would like to invite my co-host in this session, Dr. Zheala Qayyum. She is a training director, Child and Adolescent Psychiatry Fellowship, Medical Director, Emergency Physician, Psychiatric Services, Boston Children's Hospital. She's the Assistant Professor of Psychiatry, Harvard Medical School, and also Adjunct Assistant Professor of Psychiatry at Yale School of Medicine. She has done tremendous work and research in mental health, and suicide risk prevention is one of her strongest trajectories. She is one of the humblest program director that I have ever met, and I would like to put that out to that I am so grateful for her support for PAPANA and all kind of mentorship for incoming IMG applicants to psychiatry. Then we have our presenter, Dr. Javeed Sukhera, and we are extremely lucky to have him with us today. Dr. Javeed Sukhera is the Chair of Psychiatry at the Institute of Living and Chief of Psychiatry at Hartford Hospital in Hartford, Connecticut. He is also an Associate Clinical Professor at the Yale University School of Medicine. He is an internationally recognized health professions education researcher and thought leader. His research program explores novel approaches to addressing stigma and bias among health professionals. He has also been involved in advocacy and cross-sectional work in education, policy, and community services. For Dr. Sukhera, I would say he's very approachable, very humble, and very knowledgeable. So make sure you use all the wisdom he will offer us today. So with this, I will invite Dr. Zheala Qayyum to start this. Thank you.
Thank you so much, and assalamu alaikum, everyone. It's a pleasure to be here today and to be in the company of such amazing people. Islam, Dr. Nazish. So thank you for having us here today, Fawzia. This is something that is becoming more and more prevalent as the rates of adolescent and young adult suicides continue to increase over the past few decades, particularly here in the West, where we actually have the data to show it. Not to say that it's not having a global impact. I think other countries in the world are also experiencing similar rise in adolescent and young adult suicide. And I think it is where we as mental health clinicians have a particular role in educating all other healthcare professionals, because this is a public health issue rather than just a mental health crisis that is incumbent on only mental health clinicians to solve. It's going to be a group effort. And with that, I'll pass it on to Dr. Sukhera.
Thank you so much, and assalamu alaikum, everyone. It's an honor to join you today. This is my first chance to present to the group, and I'm very excited to be in my new role and also to be a resource and support to other South Asian and Pakistani psychiatrists and health professionals. So I have a few minutes to talk. I'm going to try not to bore you too much with too many details. I tend not to like to use PowerPoint too much. What I'm going to bring you is a perspective more on a practical side from a frontline psychiatrist. So I trained in both psychiatry and child and adolescent psychiatry, and worked and spent much of the early part of my career in highly acute settings, such as inpatient and emergency departments, where on a regular basis, on a day-to-day basis, I was actively and consistently involved in doing risk assessments and safety planning with young people. So just a few disclaimers before I start. This is a vast and diverse topic. There's no way that we're going to be able to cover it all, and there's no way that what we discuss today is going to be sufficient for anybody who's seeking to understand this in a comprehensive way. It's a brief overview, like I said, of practical aspects of prevention from a clinical perspective. Most of what I describe in my presentation comes from pre-pandemic literature. And there's a lot of changes that have happened related to the pandemic that I will not cover. And I would say we need to approach any generalizations about the effects of the pandemic with humility. I tend to start my presentations with some reflection and with a chance to stop and pause and honor the human space in which we work and live. The image here is from a Pakistani artist, draws upon important symbols that are lyrical, that relate to poetry, that relate to gender and identity. And the quote is from a poem by the poet Worcestershire, who wrote, "Later that night, I held an atlas in my lap, ran my fingers across the whole world and whispered, 'Where does it hurt?' It answered, 'Everywhere, everywhere, everywhere.'" We cannot have a conversation about this topic or any topic without pausing to recognize the tremendous amount of human suffering and hurt that globally is being experienced and continues to be experienced. We cannot have a discussion on this topic without honoring our own humanness, the role that we play personally and professionally in the context of this kind of suffering. And at this moment in particular, I'd like for us to think of the vast amounts of suffering that have occurred, particularly in Pakistan in recent weeks, due to a lack of sustainable and significant infrastructure for communities who have been left behind. A presentation on this topic also may evoke certain emotion. Anybody listening or watching may experience strong or intense emotion related to experiences, and it's of tremendous importance that we take great care of ourselves and one another. So thinking about this topic for me means thinking about a recent transition that I made. Approximately a year ago, I was blessed with a new and exciting opportunity to leave Canada, where I had practiced and lived for many years, and take on a position in the US. What I wanted to share with you is some of what my experiences have been in a Canadian context, and some of those thoughts and how they're being put into place in my new role. When I started working in London, Ontario, Canada, I returned home to Canada after many years to a system that I had always held up on a pedestal, a system that was supposed to be universal, supposed to be equitable. But I quickly bore witness to a system where mental health was never sufficiently invested in, and a two-tier system where access to mental health services, particularly for young people, was unconscionable. In the hospital in which I worked, at the time in which I started my career, if someone was 18 and was admitted after a suicide attempt, they could be spending weeks waiting for inpatient care. In this context, I did my best to continue to serve, to work in clinical environments, but also continue to consistently advocate for something better, recognizing that until we work hard and leverage our voices to make systems and structures better, nothing that we do clinically will have the same meaning and resonance. A lot of my early research was not about youth suicide, but it was about experiences of discrimination and mistrust. It demonstrated that there are clear cycles that people experience when they build up the courage to ask for help. And that's what I'd like you to start thinking about right now. A young person who might have built up the courage to ask for help. And think about how important it is for any of us working in the system to ensure that we respond to that courageous request with compassion and empathy that centers the dignity of this person. We will and do react. But when someone asks for help, it's not about us. The challenge is for us to center the other person, center the most vulnerable, without dehumanizing ourselves. Many times in many settings and health jurisdictions that I've worked in, the provider, the professional builds up armor. We learn to disconnect from who we really are. And it leads to a cycle of fear, labeling, avoidance, and helplessness and frustration for all involved. In this context in which I practiced, we saw hospital admissions jump for mental disorders, while hospitalizations for other pediatric conditions actually decreased. We saw emergency visits jump for mental disorders in youth, while there's only a 5% increase in other conditions. And this is pre-pandemic data. In the context of Ontario, Canada, there was also a 25% increase in doctor visits for mental health or addictions, and a 40% increase in children and youth seeing psychiatrists. And I assure you that there was not a commensurate 40% increase in the amount of child psychiatrists to do the work. In this context, we saw that access to care was very challenging. It led to increased readmissions. It led to increased difficulties with transition, and ultimately a system that was not responding to meet the need. When we think about a child and youth perspective, this is from a parent quote. She says, "When we hear about a child in our community who has died by suicide, as service providers, we are rocked with grief and frustration because we know that this death did not come out of nowhere, that there were so many opportunities along the way over years to intervene for a better outcome, that the parents of this child, like so many who call us, have found only closed doors, have been sent home from the hospital emergency with a child deemed not quite high enough risk, to lock up all the knives, the ropes, the pills, and to sleep outside their child's room lest he wake up in the middle of the night and decide that he cannot take it anymore." In this context, we looked at some of the disconnect in the system, and it was clear that patients and young people who were in crisis would have access to assessments, but would be on extremely delayed waiting lists, waiting weeks, months, years for services, leading to a cycle of powerlessness and experiences of exclusion. We made the case for better integration of hospital and community services to provide better real-time assessment and intervention for this population of youth and young adults. But what struck me the most is that thinking about my experiences in different jurisdictions, in Canada, there's this idealization of the Canadian system. Yet as far back as 2005, report with a national focus emphasized that the underinvestment in children's mental health services was simply unacceptable. And yet here I am transitioning into a new jurisdiction where we are seeing climbing rates of child and youth distress. And most recently, the Surgeon General, Dr. Vivek Murthy, shared that mental health challenges are real, and that even before the pandemic, an alarming number of young people were struggling with feelings of helplessness, depression, and thoughts of suicide. And we know that rates are increasing. So in this context, in this system, where we know that we are rarely resourced to provide young people with what they need, what is it like for us in these moments when a young person in their moment of greatest vulnerability crashes into us in a cross-section in their and our personal history? Now I'm going to share a few brief comments on how I conceptualize risk assessments. The first thing for us to remember is that there is a difference between screening, which is something that often happens in non-mental health or non-psychiatric settings, and assessments. This difference is contextually specific and varies jurisdiction to jurisdiction. It also varies in accordance with regulation of health professional designation and has medical and legal implications. In general, we know that amongst young people, and these are broad pre-pandemic statistics, but 15 to 25% experience passive thoughts of wanting to die. We know that 6% of girls and roughly 2.3% of boys experience ideation with intent, that 10% of girls attempt and 1 to 3% of boys. However, what's most important to remember is that 10% reattempted in 6 months and 42% reattempt in 21 months, which means that if we intersect with someone who has had suicidal ideation with intent or attempted, that this is someone who we have to be very considerate about how we respond to them, how we relate to them, and whether or not we represent a system that has unconditional empathy for them should they struggle again. But anything we do in terms of suicide risk assessment has to recognize a central problem, a central paradox that people often forget even when we're in practice. And this is the problem of prediction. Unfortunately, we are not able to predict the future. I wish we could. If I could predict the future, perhaps I would find ways to make inordinate amounts of money and not be the sort of public servant that I am. But all we can do as psychiatrists is help support educated prevention. We can do risk stratification at a cross-section in time. But ultimately, assessing risk is not about predicting the future. And it's important that any risk assessment be prefaced with the fact that we cannot, no one can predict the future. We can conduct an assessment in a cross-section of time, but the variables could change in 5 minutes, 5 weeks, or 5 months from that moment in time. Part of how I learned to think about risk formulation was from my training at the University of Rochester, where Dr. Pisani has a risk formulation framework centering around the risk status, which is a patient's risk relative to a specified subpopulation, their risk state, which is compared to their baseline or other specific time points for them, available resources, which alludes to the structural aspects I spoke of earlier, and any foreseeable changes that may mitigate or exacerbate risk. This formulation and this training has been very helpful for me to think about how I conceptualize risk in these cross-sections of time, thinking about that status state, available resources, and foreseeable changes. But in actuality, so much of what we do is integrative and eclectic. So the approach that I've taken towards suicide and risk assessment for young people is really centered around, for me, the concept of 4 C's. And I talked about this frequently in my previous role, conducting trainings for diverse groups of health professionals. The C's are the checklist, assessments around credibility, consideration of context, and collateral. Checklist refers to empirically derived factors that we know might be vulnerabilities, attributes or factors related to an acute clinical presentation, and access to means, because we know that access to means is an important component of the assessment. But these variables, this laundry list of evidence-based factors, has to be weighed against protective factors, the things that are attaching a young person to this world. And these protective factors, their reasons to live, their hope, whether or not they're connected to people, are among the most important aspects of what we look for during an assessment. Credibility is a little bit more tricky. So many times when I've conducted risk assessments or worked with young people, I've encountered parents and caregivers who've said, well, I'm really worried because they're really good at saying what you want to hear. And my response, because I never take myself too seriously, is to say, well, if we just base what we did on what young people say, we probably wouldn't be able to be very effective at what we're doing. That stated, it is very important to recognize that we as adults are part of a system that generally doesn't center young people and their agency or autonomy. So in the ways in which we make inferences and judgments, we really need to convey that if they're struggling, if they're in pain, that we believe them, that we know that they're not making anything up. But at the same time, we have to consider other variables and factors. For us in psychiatry, we think about things like the mental status examination, and a lot of this actually falls down to clinical intuition. Assessing and really appraising credibility is something that should be done with a great degree of humility. It's also important to recognize the vulnerability of young people and how challenging and coercive it can be in some of these circumstances, where systems and adults react to their request or cry for help in ways that take away their ability to make informed choices. And then we have to think about context. What's really going on in this person's life? What's the different parts of who they are, the stories that make them the unique individual that's presenting before us? What's happening with relationships, family, interpersonally, school? What kinds of transitions are they experiencing? What's happening related to work or other aspects of their lives, finances, global and socio-political stressors? And what's happening with them academically, with school? What part of the school year is it? Where are they at in their academic training? And how does this relate to what's happening? But there is no way to do a risk assessment without considering the role of the caregiver. And although this image is quite tongue-in-cheek, it's essential that we engage with parents and caregivers as central partners with whom we build a trust and alliance and support. These are people who are very stressed and times traumatized. And we have to take a very trauma-informed approach that understands, appreciates, and practices our ability to be in their shoes. The other thing that we don't have time to cover, but it's important to address, is some of the ways in which self-harm, also sometimes known as non-suicidal self-injury, gets conflated with suicide risk. Although there is some degree of overlap, there are also considerable differences. The nuances related to this are outside of the scope of the talk today, but it's important to remember that in many cases, ideation about harming oneself can be an effective way to cope with distress, even though it's ultimately maladaptive and unhealthy, which is why reacting to self-harm in ways that doesn't recognize one's need to build and substitute unhealthy coping with healthy coping skills can actually cause potential harm. Now I'm going to briefly talk about the concept of safety planning, understanding what it is and how it can assist us in developing and addressing suicide risk formulations. So safety plan comes from cognitive behavioral therapy literature, and it's built around a stress diathesis model. Essentially, a safety plan really is many things. In my own practice, I've considered a safety plan to be an agreement between two parties, but not a contract. We don't apply contracts around suicide, as that practice is not one that's recommended, although has been used at times in the past. It's also a prevention tool. So it allows us to really engage around potential adaptive problem solving, how adaptive a young person's thinking is around how they can take steps to prevent and mitigate risk. But in addition to that, a safety plan is a therapeutic exercise. It's an opportunity to engage, create space, and cultivate hope. So it is more than simply something that's a tool to assess risk. As I shared earlier, it's come from a cognitive behavioral therapy theoretical grounding. And it really is about asking a young person to describe the events that might have led them to thoughts or actions, and then really complemented by psychoeducation and hope. Typically, safety planning in this model falls around a targeted behavior and involves a list of early warning signs, a list of coping methods or distracting activities, but most importantly, a list of communication strategies, including an escalation plan. Among the most important questions to ask a young person who might be struggling is, who are you closest to? Who do you trust? And if their responses are same-age peers, to ask specifically about adults and adult supports. If they say that they struggle with speaking to their parents, that's a chance for us to zoom in and better understand the ways in which family communication happens. Because I would argue that in families where young people struggle to be open about their vulnerabilities or suffering with their parents, those cases are among the ones with greatest risk that I'm most concerned about. When we're conducting safety planning, it's also important to think developmentally and remember that this isn't an exercise that a young person can always just come up with answers. So we can provide prompts and consideration of how different warning signs, coping skills, and communication strategies vary at different degrees of distress. Ultimately, family involvement is another crucial component of this exercise. And we have to consider that there may be atypical young people who struggle in different ways, cultural and linguistic complexity that has to be part of how we approach this exercise as well. One of the things that I'm most proud of in my career was being part in our jurisdiction of co-designing an app called Be Safe, which is an app that was designed by youth and for youth with adult consultants. Be Safe is still available in Ontario, Canada, and it includes prompts to allow young people to participate in building a safety plan, integrating it into their daily life, and actually having scripts on what to say if they're distressed and don't know what to talk about. So with all of this, I've covered a lot of topics. And there's no way for me to comprehensively cover all the warning signs. And I'd say that it's important that presentations like today be augmented and complemented by more scholarly and scientific trainings and presentations. But I do want to conclude with a few remarks about the path forward and some things that I've learned and consider in my daily practice. One of the most brilliant resources that I've come across is actually developed by Youth for Youth. It's developed by an organization called jack.org, and it's available online at the website bethere.org. There are many training programs such as Assist, Safe, as well as the mental health first aid. But this amazing and simple framework from jack.org is a very useful tool for young people who might be wondering about what they can do for other young people who are struggling, or lay people in our lives who aren't experts or who don't work in the area, but are looking for advice and guidance on how to approach it when a young person is in distress. Bethere.org has developed 5 golden rules, which I think are very simple and elegant, but describe the importance of leaning in when someone's struggling and not being afraid of the darkness that they might be experiencing. It simply involves saying what you see, which is noticing when someone might be struggling, demonstrating tangibly that you care, listening deeply for both what's said and unsaid, but knowing your role and setting boundaries to protect your relationship and your own mental health, recognizing the limits around individuals' scope and role and expertise, and ultimately to connect them to help, offer support, to help find resources, to get help and know what to expect. The other really important lesson in so much of my work is that of practicing compassion for ourselves and those of us who work in these spheres. We live and work in cultures that are excessively perfectionistic. Many of us, like myself, who come as first-generation immigrant families, among whom there's a considerable degree of minority stress, settlement and resettlement trauma, and expectations which at times can be extremely unhealthy and maladaptive. We live and work in cultures which push us towards self-blame, self-criticism, and self-doubt. And so practicing consistent self-kindness, self-validation, and self-compassion are crucial. When I think about the approach that I take to practice, to life, to my work in research and equity and bias, it really is about enhancing the agency of the other, centering them and their ability and right to choose, role modeling vulnerability and breaking cycles of perfectionism, but ultimately co-designing a path forward, humbling ourselves to the individual or the young person's expertise and who they are and the life that they lead. And with that, I will conclude and pass it back to Dr. Qayyum.
Thank you so much. That was extremely comprehensive, even if it was in a very short amount of time. I'm going to just highlight a few things that build on Dr. Sukhera's presentation, and I'll see if I can share my slide deck. Great. So I think something similar that we experienced was that, particularly during the pandemic, what was described by Dr. Sukhera before about kids boarding in the emergency rooms or not being able to get help in a timely manner was only worsened during the pandemic. And as a medical director of emergency psychiatry services in a children's hospital, I think we really saw the brunt of it during the pandemic, where services for kids also diminished, and there were a multitude of factors that really made this worse. And so it was all over the news. We had very unhappy parents and families who had to wait for weeks to months to get their child help or an inpatient bed if they needed more stabilization. And it was a reality we had to live with, where I think for myself, at any given time, I could have 30 to 40 children waiting in the emergency room and another 50 boarding on the medical floors. And so just to build on what Dr. Sukhera already said, what happened during the pandemic? And so this is the US Center for Disease Control and Prevention's survey on adolescent behaviors and experiences during the pandemic. And the part I'm just going to focus on is where they looked at suicidality and also a sense of connectedness and what happened to the mental health of adolescents during this time. So this was, I'm not going to go into the nitty-gritty of the study. It's available publicly. But this was a survey that was done in public and private schools. They had over 7,500 adolescents between 9th and 12th grade. And they really looked at what was happening to their mental health and suicidality during the pandemic. And one of the things that was obviously experienced by most parents and children and adolescents was that life was disrupted for people who really needed structure the most. And it impacted their schoolwork. It had economic impact on the family that really trickled down. Even if parents thought they were shielding their kids, this was something that was quite palpable for many, many young folks. And because people were sort of confined in their homes, the rates of emotional and physical abuse actually went up. And more than half of the students experienced emotional abuse by a parent, and more than 10% of them reported physical abuse. Here in the US, this was more for minoritized populations and underrepresented populations as well. But what they really were focusing on was the mental health during the pandemic, and 44%, so that's almost half the adolescents, had experienced feelings of sadness and hopelessness. And to compare this with the statistics that Dr. Sukhera just put out, about 20% of them had seriously considered attempting suicide, and 9% had attempted suicide. And this was, I think, 6% and 2.3% in the previous slide for pre-pandemic. And then this was also much higher for female students and minoritized populations. But another thing that was also highlighted was a sense of connectedness. What does feeling close to someone at school, whether it was virtually, to your peers, how did that mitigate this risk? And what they found was that the sense of connectedness was higher for male students compared to female students, and also here for white students compared to other racial and ethnic minorities. And this sense of connectedness, I think, is really important. And Robert Brooks, who's a psychologist here at Harvard, really defined this as a charismatic adult is a person who a child feels connected to and from whom the child gathers strength. This strength helps children manage through adversity and to persevere despite setbacks. So the sense of connectedness, whether it be to a charismatic adult or to their peers, knowing that they have some support and they mean something to someone, can be a really important protective factor to assess for. What is keeping you in this world? Who do you want to stay for? And unfortunately, for young folks who have a lot going on at home, sometimes this charismatic adult or the people that they feel most connected to are people at school, which is really disrupted. And as would be expected, those young folks who had a greater sense of connectedness to peers and to people at school had better mental health outcomes. They had lesser feelings of sadness and hopelessness. Their suicidality was less and their suicide attempts were less as well. Another thing I just wanted to highlight was, I think this notion that was raised by Dr. Sukhera as well, is this predicament about being able to predict versus being able to prevent.
Recording in progress.
Sorry. So one of the areas that I'm most interested in, given my work in the emergency room, and before that as the medical director of adolescent and young adult inpatient units, was what happens when patients die by suicide. And over the years, being in acute psychiatry, I've had a few patients who've died by suicide. So as I think Dr. Sukhera mentioned, this predicament between prevention and prediction, the societal expectation is that we as mental health clinicians should be able to prevent suicide, or that there is a zero suicide initiative, that one suicide is one too many, which is true. We should do whatever we can to prevent suicides that are preventable, but there will be times where they are not. And when the benchmark is set at zero suicides, anytime it happens feels like a failure on part of the clinician. And so knowing that in terms of screening and assessment and safety planning, once done, all that we can reasonably do in as much as best practice parameters dictate, being prepared for death, because it is part of what we do when we treat people. And one of the things that I think needs to shift in terms of how we are talking about mental health is that when we're thinking about youth mental health, we don't talk about prognosis as much as we should. That this is the natural outcome of certain mental health illnesses, particularly without intervention, and why mental health treatment is so important, and to break through all the stigmas and the barriers that are sort of posing difficulty in accessing and implementing treatment. And with that, I think I'll end my portion so we have some time for questions. You're muted, Fazia.
Oh, sorry. Thank you very much, Dr. Sukhera and Dr. Qayyum, for this sharing your thoughts and these wonderful presentations. So from there, I would like to take a few questions that I can see in the chat, and we have also received before. Our first question is from Adil Ilahi, that an adolescent with suicidal intent, what is the plan of action with regards to the adolescent parents, peers, and teachers?
So maybe I can start. I think that
Yes.
part of what I would recommend is that we not come into that kind of encounter with a plan of action, that we focus on co-creating and discussing a plan of action with the adolescent, with the parent, and then to the degree that the adolescent want them involved, the peers and teachers. There's a lot of how we approach healthcare and medical practice that can be paternalistic. And I think that approaching young people with humility is a key component of best practice when it comes to this work. why this matters is because we know that when a young person's intersecting with the healthcare system for the first time, how we approach them will affect their help seeking into the future. And so if we approach them in a way that diminishes their agency, their choice, that's going to potentially make them less likely to reach out, less likely to ask for help, and then have significant adverse effects on their future. So I'd say the plan will depend. And the answer to any good question, especially in our field, is that it depends.
I absolutely agree. I think the one area that I usually do try to discuss with adolescents and caution them about is involving peers. I know there's some of the first people they will reach out to, but just being cognizant of what responsibility for some peers' safety is being put on another young person. And so working with the team to identify who are the people that they can actually reach out to in the moment without burdening their peers unnecessarily, because it can be a lot for another young person to be put with being responsible for the safety of their peer.
Thank you. And another question from Huma Bakar is, how effective is distraction as a way to cope with suicidal thoughts?
I think, again, when we look at a safety plan, we start with what really works for the person in the moment. What are the things that they can identify? And there is a standardized instrument usually used, which goes into a stepwise progression based on the intensity of thoughts. So for milder thoughts or mild distress, distraction can be fairly useful for people to keep themselves engaged. But for stronger thoughts, they may have to do something very different. And again, this is part of where treatment with a trusted provider, where you can actually share what is going on, what is driving these thoughts, and what triggers them, where they come from, how do you best manage them, is very individual. For some people, distraction might work, and for some others, it might not. It's really figuring out what is the best plan to keep somebody safe that works for them. And we can give them some ideas, but distracting might work in certain situations, but it won't make the trigger or where these thoughts are coming from go away.
Okay. Next question is from Yasir Mahmood. Do you think clinicians need to train to better understand suicidal behavior in the social and historical context, especially for minorities like Black youth?
So I would say a resounding yes to that question. Far too much of our current paradigm in psychological research and psychiatry has been built around a Eurocentric frame that neglects the ways in which other diverse groups, cultures, and ethnicities experience the world. An example of this has come from my own journey in unlearning some of the things that have been taught in my training when working with Indigenous young people and families in a Canadian context. I remember very poignantly one of the first conferences I went to, there was a young person on a panel who really just bluntly said that so much of the research that informs even the things I talked about earlier today has not been built around communities like his, nor has it included participants like him. I think far too much of our existing paradigms, even on things like self-disclosure, really are coming from a colonial perspective, and that much work needs to be done to decolonize our approaches for all types of groups and identities. An example here is the excellent work amongst Muslim mental health experts on understanding the nuanced ways in which spirituality and religion can serve as both a protective factor and a risk factor. I think the context entirely depends on the unique role that religion and spirituality might play for that individual child and family. I am not an expert in Black health, and I would defer to the many Black scientists who we should cite and recognize for their expertise. So I can't speak specific to that, but I do believe that the approaches that we take need to be much more differential and consider minority stress as part of the issue as well.
Thank you. Another question from Dr. Zubi Salman. Any data reflecting increase in substance abuse and increase in eating disorders leading to suicide during pandemic?
I mean, off the top of my head, I can say that the eating disorders literally doubled during the pandemic, at least in my hospital, and we actually published that data. So even though the volume of other medical admissions fell, presentation for eating disorder doubled. And that was pretty much the same data we got from pediatricians, that they were managing a lot more eating disorders in the community, even if they did not require hospitalization. And similarly, the CDC, as part of the Adolescent Behavioral and Experience Survey, found that substance abuse also went up here in the US. I can't speak to other places, but definitely there was an increase in substance use, and particularly those adolescents who had not tried anything were using alcohol and tobacco more. And those that were using substances before noticed that they were using more of the same substance during the pandemic.
Thank you. Another question from Zubeda Siddharth is, can you share the list of the early signs?
So I cannot. I would suggest looking that up. There are many resources, practice guidelines, and textbooks. But I would say that the lists themselves and the checklist portion of what I described are important for folks to get acquainted with and spend time marinating in the literature to get.
Okay, there is another question from.
A quick thing I would add is that knowing that suicidality is going to look very different in children and adolescents than it does in adults. And there is a huge component of impulsivity that is very particular to our adolescent and young adults. So there may not be a lot of warning signs or early signs that you might see, and it may be just a reflection of just how much pain and distress they're in. And if means are available, they might do something very impulsively. Like I think some studies have shown that the time between thinking about suicide and acting on and making an attempt for adolescents is not like in adults where they're giving away things and making a proper plan. It can be anywhere from 15 to 25 minutes. And so if something is available at home and within reach, that is what really confers additional risk to this population.
Thank you. Another question from Dr. Mohammad Khalid Zafar. What's the current evidence of effective strategies to prevent suicide in adolescents? How much evidence is there for hospitalization?
So I think what we've all collectively experienced in the past 2 years is a disruption in everything we know. I would say that a lot of our existing paradigms, which involve putting young people into involuntary hospitalization, can be at times the approach that we take. But I would challenge us to actually start to critically question some of the coercive underpinnings of how we constitute evidence. The most important thing, like I've said a few times today, is the kind of space we create. And I'm not going to get into a scientific answer with citations, but I'm going to say that it really is about how we react. I think Dr. Imran made an astute comment about, in a Pakistani context, the attitude of the worker, or I would say in any context, the attitude or preconceptions of the adult even before they intersect with a young person about what suicide means, are part of what we need to question. Recognizing and normalizing the fact that we all struggle and that we all experience pain is essential, because far too often we treat struggles and unhealthy coping as abnormal, when we have to recognize that we all learn and exercise healthy in unhealthy ways of coping. You know, some of us, present company included, in terms of the amount of time I might spend on my phone. So what's the evidence for hospitalization? Well, I'd say that there are evidence-based strategies. There's a collection of evidence-based strategies, but the greatest evidence, like Dr. Qayyum cited, is about connection for young people, particularly with trusted adults. And I think that's the point, take-home point I would convey today.
Thank you very much. And this is going to be our last question. From Usman, is there a role of focused DBT in the ER setting for kids with personality disorders, especially borderline, presenting with suicidal ideation?
Is there a role? Absolutely. Do we have the time and the force to do it? I certainly hope we will someday. I think that will be one of the things to really focus on when we're trying to come up with strategies to minimize risk and interventions that we can do to prevent hospitalizations when we can. Again, part of the limitations of why hospitalization is used is when community supports are either deficient or not enough to maintain someone safely. But if we can do those interventions in the emergency room and create change and a different disposition plan, absolutely. I think that would be the way to go. I just hope that we can get the funding and the training and the people to be able to do it. You're muted, Marcia.
And we can see Dr. Mohammad Zishan is here. We would like him to just give any suggestion for suicide prevention.
Assalamu alaikum. Thank you so much for organizing this. I think the one thing that, the suicide is just a message of hope, and hope and faith. I think sometimes it can be very difficult when you are in that situation. And I think just keep attending these webinars and just keep hope and faith as the key moderator. Sorry, there's a lot of background noise, but thank you for organizing this.
Thank you very much, Dr. Zishan. So thank you very much, Dr. Qayyum, Dr. Sukhera, for this comprehensive presentation. Thank you very much for your time. And I would like Dr. Qayyum to just conclude this with a message, with a suggestion. Thank you.
Oh, thank you so much. And thank you, Dr. Sukhera, for a wonderful presentation and your wisdom, and for Fawzia for putting all of this together. This is something that I think is near and dear to all of our hearts who work with kids and adolescents. It is our future that we're trying to protect. And I agree with Mohammad Zishan that we have to still think about hope and knowing that human struggle and human emotions are a normal part of our existence and being, which is why we are psychiatrists. We are there to help heal the soul. And we just hope that we can work together to come up with all the strategies and the systemic changes to be able to support our youth so they can stay safe and healthy. So thank you again.
Thank you. Thank you, everyone, for your time. Bye.
Thank you.